Welcome to this comprehensive clinical review on vertigo. This lecture covers the clinical presentation, pathophysiology, diagnostic workup, and management of vertigo. Vertigo is one of the most common complaints encountered in clinical practice, affecting 5% or more of adults each year. By the end of this lecture, you will have a thorough understanding of the vestibular system, the various causes of vertigo, how to differentiate peripheral from central causes, and the available treatment strategies. This review is based on the latest evidence from Medlink Neurology. Our learning objectives for this lecture are as follows. First, we will define vertigo and distinguish it from other forms of dizziness. Second, we will review the anatomy and pathophysiology of the vestibular system. Third, we will learn to differentiate peripheral from central causes of vertigo using clinical features. Fourth, we will master key clinical examination techniques, including the Dix-Hallpike maneuver, the head impulse test, and the HINTS examination. Fifth, we will explore diagnostic algorithms used in emergency settings. Finally, we will discuss the management of vertigo, including pharmacological, rehabilitative, and surgical approaches. Vertigo is defined as an illusion of movement due to an imbalance of tonic vestibular activity within the central or peripheral vestibular pathways. It is usually rotatory, implying a disturbance of the semicircular canals or their central connections. However, sensations of body tilt or impulsion may also occur, indicating otolithic disturbances or dysfunction of central otolithic connections. Vertigo is commonly associated with nystagmus, oscillopsia, postural imbalance, and autonomic symptoms such as sweating, pallor, nausea, and vomiting. Vestibular vertigo is a remarkably common problem, affecting 5% or more of adults each year, with an annual incidence of 1.4% in adults. Its prevalence rises with age and is about 2 to 3 times higher in women than in men. Let me highlight several essential key points about vertigo. Episodic vertigo is generally of abrupt onset, but the duration of episodes varies considerably and is a critical diagnostic clue. Episodes of benign paroxysmal positioning vertigo last seconds up to a minute, whereas seizures generally last seconds or minutes. Migrainous vertigo may last minutes to days. Transient ischemic attacks last minutes to hours, and attacks of Meniere syndrome last hours. Monophasic vertigo may have an abrupt onset, as seen with trauma, stroke, or demyelinating disease. A subacute onset, as with vestibular neuritis, or a subacute to chronic onset, as with toxic vestibulopathy or posterior fossa masses. Peripheral vestibular nystagmus is a mixed linear rotatory jerk nystagmus that beats in one direction away from a hypofunctioning labyrinth. Importantly, drugs should be reviewed in all patients with dizziness, and vestibular exercises should be begun as soon as possible after symptom onset to accelerate recovery. Drug-induced dizziness is an important and often overlooked cause that should be reviewed in all patients presenting with dizziness, whether clearly vertiginous or not. Drugs associated with dizziness include alcohol and other central nervous system depressant medications such as benzodiazepines, barbiturates, and phenothiazines. Aminoglycoside antibiotics are well-known ototoxic agents. Anticonvulsants, antidepressant medications, antihypertensive medications, chemotherapeutic agents, loop diuretics such as furosemide, and salicylates can all cause dizziness. The elderly are particularly susceptible to drug ototoxicity because they are more likely to receive ototoxic drugs, they have less vestibular reserve due to age-associated changes, and they are more likely to have impaired renal function affecting drug clearance. Occupational exposure of healthcare staff to static magnetic stray fields from MRI scanners is also associated with transient vertigo symptoms. Section 2. Historical note and terminology, slides 6 to 7. The study of vertigo has a rich historical background. English physician Erasmus Darwin, the grandfather of naturalist Charles Darwin, described physiologic vertigo and its dependence on rotation in the late 1700s and early 1800s. From 1820 to 1827, Czech anatomist Jan Evangelista Purkinje established the method of rotation to study vertigo, thoroughly described apparent movement of the visual field during and after rotation, and discovered that the axis of apparent after rotation varies with the position of the head. French physiologist Jean-Pierre Florent performed key studies showing that section of semicircular ducts produces muscular incoordination maximal in the plane of the sectioned canals. In 1870, German physiologist Friedrich Leopold Goltz found that caloric irrigation of the external auditory canal produced vertigo, nausea, and nystagmus. In 1871, Eduard Hitzig produced similar phenomena with electric currents applied to the head. In the 1870s, considerable progress was made in understanding the function of the peripheral vestibular system. Austrian physicist Ernst Mach proposed in 1873 that a change in speed of rotation, that is angular acceleration, would produce pressures within the semicircular ducts that would vary in intensity as a function of the components of rotation in the planes of the respective canals. Mach also proposed that the maculae in the vestibular otolithic organs were responsible for sensing linear acceleration. Austrian physician Joseph Breuer and British physician Alexander Crumb-Brown described similar results in 1874 and 1875 respectively. Importantly, Crumb-Brown noted that the symmetrical pattern of the canals on the two sides of the head meant that canals in the same plane on the left and right sides were reversed in function, with counterclockwise rotation stimulating one and clockwise rotation stimulating the other. This push-pull mechanism forms the foundation of modern vestibular physiology. Section 3, Anatomy, Slide 8. The osseous labyrinth housing the vestibular receptors lies in the petrous temporal bone, with the three semicircular canals on each side oriented roughly orthogonally to one another. The superior canal on one side is in approximately the same plane as the posterior canal on the opposite side, and the lateral or horizontal canals are in approximately the same plane bilaterally. The membranous labyrinth lies within the osseous labyrinth and includes the three semicircular ducts for sensing rotary motions of the head and the utricle and saccule for sensing linear accelerations. An important clinical detail is that the lateral or horizontal duct is actually tilted 30 degrees from the horizontal plane. The head must be tilted 30 degrees forward from upright to make the duct orientation truly horizontal. This is why we position patients with the head tilted forward during caloric testing. Section 4. Clinical manifestations, slides 9-14. Vertigo presents as an illusion of movement due to an imbalance of tonic vestibular activity. It is usually rotatory, but sensations of body tilt or impulsion may also occur. Vertigo is commonly associated with nystagmus, oscillopsia, postural imbalance, and autonomic symptoms. Importantly, autonomic symptoms such as sweating, pallor, nausea, and vomiting are generally more severe with vertigo of peripheral origin than with vertigo of central origin. Precipitating factors for vertigo may include head movements, coughing, sneezing, and loud noises. Head movements can produce vertigo even after compensation has occurred. Coughing and sneezing may precipitate vertigo, particularly in patients with superior semicircular canal dehiscence. Loud noises may precipitate vertigo in patients with inner ear disease, such as Meniere disease. This is called the Tullio phenomenon. Most patients with central positional vertigo have clinical findings indicative of central lesions, such as downbeat and apogeotropic horizontal nystagmus, cerebellar ocular motor abnormalities, and truncal ataxia. In one study, 62% of patients with central positional vertigo had paroxysmal attacks, whereas 31% had non-paroxysmal vertigo and 8% had paroxysmal evolving to non-paroxysmal vertigo. The most common patterns of positional nystagmus evoked with maneuvers were positional downbeat nystagmus at 69%, apogeotropic horizontal nystagmus at 42%, geotropic at 8%, and multiplanar at 23%. Notably, half of the patients in this series had brain imaging before central positional nystagmus was on the differential diagnosis, underscoring the importance of clinical evaluation. The so-called acute vestibular syndrome is characterized by the acute onset of vertigo or dizziness, intolerance of head motion, spontaneous or gaze-evoked nystagmus, gait unsteadiness, and a duration of at least 24 hours. This specific subset of acute dizziness patients has been categorized to help identify, in conjunction with specified examination findings, patients with acute stroke who present with acute vertigo or dizziness to emergency rooms. The problematic inclusion of a specified duration of at least 24 hours makes this a presumptive consideration in most emergency room situations because most patients present before that time threshold has been reached. Furthermore, critical decision-making such as administration of intravenous tissue plasminogen activator has to be made before this time threshold. Postural instability associated with vertigo varies by etiology, age, residual vestibular function, and disease duration. Truncal ataxia has been categorized in a 4-point grading system. Grade 0 indicates no imbalance with walking independently. Grade 1 indicates mild to moderate imbalance with walking independently. Grade 2 indicates severe imbalance with standing and inability to walk without support. Grade 3 indicates falling with upright posture. In patients with acute vestibular syndrome, Grade 3 truncal ataxia is strongly suggestive of acute stroke, as is Grade 2 truncal ataxia in combination with other central nervous system signs such as nystagmus of central origin. This grading system is clinically useful for risk stratification in the emergency department. Although the prognosis and complications of vertigo are heavily dependent on the underlying causes, vertigo is an important contributor to population attributable disability, particularly among the aged, and is often associated with significant comorbidities and serious consequences, including falls, traumatic injuries, loss of autonomy, and institutionalization. Psychological distress is an important component of vertigo-related handicap. Vertigo is strongly associated with both an increased tendency to fall and an increased injury rate from falls among adults. Anxiety and depression are more common in some types of vertigo than others. In particular, anxiety and depression are more common in patients with Meniere disease and migrainous vertigo than in those with benign paroxysmal positioning vertigo or vestibular neuritis. In children, chronic vertigo has a negative impact on health-related quality of life. Let us consider our first clinical vignette. A 57-year-old man with a history of alcohol abuse was referred for evaluation of acute onset of dizziness and falls. He reported sudden onset of dizziness, imbalance, vertical diplopia, and numbness on the right side of the face and in the left leg. On examination, he had prominent anisocoria with a right ptosis and meiosis consistent with a right Horner syndrome. He had a left hypertropia and nystagmus, right facial hyposthesia, mild dysmetria of his right arm, and a slightly wide-based gait with tendency to fall toward the right. Sensation was decreased to pinprick in the left leg. This patient had acute onset of vertigo associated with neurologic signs that persisted for days. In his age group, the most likely cause would be a stroke. Examination confirmed Wallenberg syndrome, a lateral medullary infarction. Danijars, Section 5, Case Studies, Slides 15-17. Our second case involves a 53-year-old woman with a 6 to 7 week history of episodic dizziness and vertigo that began after a bad cold. She became dizzy when getting up in the morning, with the room spinning during episodes lasting about 5 minutes. Episodes were triggered by bending down or raising her head. On examination, the Dix-Hallpike maneuver with the head turned toward the left produced an upbeating rotatory nystagmus after a latency of 5 to 10 seconds, subsiding after an additional 10 to 15 seconds. Repetition produced identical but lesser symptoms, demonstrating fatigability. This patient had episodic vertigo that was relatively brief. Examination excluded static vestibular dysfunction and established a diagnosis of benign paroxysmal positioning vertigo referable to her left posterior semicircular duct. She was treated with a Semont liberatory maneuver with resolution of her symptoms and signs. Our third case is particularly instructive. A 51-year-old man presented with sudden hearing loss in his left ear, vertigo, and imbalance. 3 times over the previous week, he had experienced transient hearing loss and vertigo lasting 5 to 10 minutes. He had a history of hypertension and heavy smoking. A pure tone audiogram showed mild left sensorineural hearing loss with a pure tone average of 37 decibels. MRI diffusion-weighted imaging was initially normal, but perfusion-weighted imaging showed territorial perfusion deficits in the left posterior inferior cerebellar artery and anterior inferior cerebellar artery territories. Brain CT angiography revealed occlusion of the left intracranial vertebral artery and multifocal stenosis of the right intracranial vertebral artery consistent with vertebral artery dissections. Follow-up imaging 3 days later showed multifocal infarctions involving the upper cerebellum and occipital lobe. The follow-up diffusion-weighted imaging and apparent diffusion coefficient mapping performed 3 days after onset demonstrated multifocal infarctions along the posterior circulation involving the upper cerebellum and occipital lobe. After initiating treatment with clopidogrel and high-intensity atorvastatin, his vertigo gradually improved, but his hearing loss did not change. 2 months later, he had no vertigo but still had hearing impairment in his left ear, with a follow-up audiogram documenting persistent left sensorineural hearing loss with a pure tone average of 53 decibels. Perfusion CT showed that perfusion deficits remained in the left cerebellum. This case powerfully illustrates that sudden hearing loss with vertigo can be a harbinger of posterior circulation stroke from vertebral artery dissections. Section 6, Biological Basis, slides 18 to 21. Vertigo indicates dysfunction or imbalance within the central or peripheral vestibular pathways. Rotatory vertigo implies a disturbance of the semicircular canals or their central connections, while sensations of body tilt or impulsion indicate otolithic disturbances. Neurologic symptoms associated with vertigo are particularly helpful in localizing the responsible lesions. Hearing loss and tinnitus generally imply peripheral dysfunction involving the inner ear, internal auditory canal, or cerebellopontine angle structures. Because the motor fibers for facial expression pass in the 7th cranial nerve in close proximity to the vestibulocochlear sensory fibers in the 8th nerve, peripheral-type facial paresis may be associated with lesions of the internal auditory canal, cerebellopontine angle, or brainstem. Any of the following imply an intracranial basis: diplopia, facial numbness, dysarthria, dysphagia, extremity weakness or numbness, or incoordination. Rarely, cerebral lesions in the anterior insula or parietal cortex can present with vertigo. Cortical stimulation studies in epileptics have identified vestibular cortical areas in both the temporal and parietal lobes. The posterior insular cortex has been identified as an essential area for vestibular otolith perception and is considered a core region of the human vestibular cortical network. Vertigo or dizziness is a common aura in patients with epilepsy undergoing video EEG monitoring. The temporal lobe is the most frequent ictal onset area. In a study of 831 patients, vertigo or dizziness was the most frequently encountered aura at 4.8% of the sample population. In 27 children presenting with vertigo, the most common etiological factor was inner ear malformation at 22%, followed by cochlear implant surgery and migraine at 11% each. Video head impulse testing and the SHIMP paradigm are effective vestibular tests for distinguishing peripheral from non-peripheral etiology in the pediatric population. The vestibular receptors are housed in the bony labyrinth, a series of intercommunicating cavities in the petrous portion of the temporal bones. From a central cavity called the vestibule arise 3 semicircular canals and the cochlea. Within this bony labyrinth is the membranous labyrinth, filled with endolymphatic fluid and specialized structures for vestibular and auditory sensation. The membranous labyrinth receives its vascular supply from the internal auditory artery, usually originating from a branch of the basilar artery. Sensory information from the vestibular receptor organs is conveyed centrally by the 8th cranial nerve through the internal auditory canal to synapse in the vestibular nuclei on the floor of the 4th ventricle. The vestibular nuclei integrate inputs from the vestibular receptors, the visual system, the proprioceptive pathways, and the cerebellum. They project to the parietotemporal cortex for motion perception, to oculomotor nuclei for vestibulo-ocular reflexes, and to the spinal cord for vestibulospinal reflexes. After unilateral peripheral vestibular lesions, neural activity in the ipsilesional medial vestibular nucleus is markedly decreased, resulting in static and dynamic asymmetries of the vestibulo-ocular and vestibulospinal reflexes. Static vestibular symptoms include spontaneous nystagmus and postural deviation, while dynamic symptoms include oscillopsia and ataxic gait. These symptoms gradually recover through vestibular compensation. In the initial process, plastic changes in the cerebellar vestibular and vestibular commissural inhibitory pathways suppress neurons in the contralational medial vestibular nucleus, resulting in more symmetrical resting activity, albeit at low levels. Short-term administration of diazepam, a GABA-A receptor agonist, accelerates this initial process. In the late process, resting activity of neurons in the ipsilesional medial vestibular nucleus gradually recovers due to changes in cell membrane properties. Long-term administration of beta-histine, a histamine H3 receptor antagonist, accelerates this late process. Dynamic compensation is facilitated by early ambulation and vestibular rehabilitation exercises. Chuck Section 7, Epidemiology, Slides 22-24. Vestibular vertigo is a common problem, affecting 5% or more of adults each year, with an annual incidence of 1.4% in adults. Its prevalence rises with age and is about 2 to 3 times higher in women than in men. Vertigo tends to recur, particularly among older women. In a cohort study of over 1,000 community-dwelling older adults aged 55 years and older who did not have dizziness at baseline, the cumulative 10-year incidence of dizziness was 40%, vestibular vertigo was 27%, and non-vestibular vertigo was 12%. Age and presence of migraine were significant predictors of incident dizziness. Diagnostic patterns vary by specialty. Otolaryngology diagnoses are dominated by benign paroxysmal positioning, vertigo, psychogenic dizziness, and Meniere disease, whereas emergency room diagnoses are dominated by cardiac, neurologic, and other categories. Several risk factors for vertigo have been identified across different populations. In adolescents, gender, stress, muscular pain in the neck and shoulder region, sleep duration, and migraine were identified as independent risk factors, with a population attributable risk of 26%. Sleep apnea is a risk factor for vertigo in adults. Among emergency department patients, age, history of hypertension, coronary artery disease, and vertigo unresponsive to treatment were significantly associated with a central cause. In a cohort study of hypertensive patients, vertigo had a prognostic impact with a hazard ratio of 2.4 for stroke death. In children, the 1-year prevalence of vertigo was 1.6%, and children with vertigo had significantly higher odds of attention deficit disorder, learning disability, developmental delay, and intellectual disability. The relationship between vertigo and stroke risk is clinically important. In a hospital-based study of 301 patients experiencing vertigo, 19% had stroke. Older age of 60 years or more, diabetes, atrial fibrillation, previous history of vertigo or inner ear disease, focal muscle weakness, dysphagia, or ataxia were associated with a higher risk of stroke. In a large study of nearly 78,000 patients admitted after presenting with dizziness, vertigo, or imbalance, independent predictors of acute ischemic stroke included an admission presentation of imbalance, African American race, history of hypertension, diabetes mellitus, hypercholesterolemia, tobacco use, atrial fibrillation, and prior stroke. Patients with systemic cancer have a significantly higher risk of brain metastases if they report vertigo coexistent with headache, ataxia, seizures, visual symptoms, or altered mental status. Section 8. Differential diagnosis, slides 25-29. A careful history, provocative testing, and detailed examination will allow distinction of the major categories of dizziness in most cases, and will often allow a specific etiologic diagnosis. Particular attention should be given to the onset, duration, and course of the vertigo, as well as any associated autonomic, auditory, or central nervous system signs and symptoms. In elderly patients, frequency of symptoms and dizziness handicap increase with age, but they less frequently report coexisting symptoms. Multisensory deficit, central vertigo, bilateral vestibulopathy, and BPPV are more common in elderly patients, whereas persistent postural perceptual dizziness and vestibular migraine are more common in younger age groups. Common causes of vertigo in young adults include migraine-associated vertigo, viral neurolabyrinthitis, psychogenic dizziness, Meniere syndrome, trauma, toxins, and demyelination. In children, common causes include migraine, benign paroxysmal vertigo, otitis media, and viral neurolabyrinthitis. The duration of vertigo episodes is one of the most important diagnostic clues. Episodes of benign paroxysmal positioning, vertigo last seconds up to a minute. Seizures generally last seconds or minutes. Migrainous vertigo may last minutes to days. Transient ischemic attacks last minutes to hours, up to a day by definition, but generally less than 6 hours. Attacks of Meniere syndrome last hours. Vestibular paroxysmia, a neurovascular compression syndrome of the 8th cranial nerve, is characterized by brief attacks of vertigo lasting seconds to minutes, often occurring multiple times daily with accompanying nystagmus and unsteadiness. Monophasic vertigo may have an abrupt onset, as with trauma, stroke, or demyelinating disease. A subacute onset, as with vestibular neuritis, or a subacute to chronic onset, as with toxic vestibulopathy or posterior fossa masses. Distinguishing peripheral from central vertigo is a critical clinical skill. Peripheral vertigo is characterized by severe autonomic symptoms, possible hearing loss and tinnitus, absence of central nervous system signs, and nystagmus that is suppressed by fixation. Central vertigo typically presents with milder autonomic symptoms, central nervous system signs, and nystagmus that is not suppressed by fixation. Peripheral vestibular nystagmus is a mixed, linear rotatory jerk nystagmus that beats in a single direction away from a hypofunctioning labyrinth. Central nystagmus may have a pendular appearance, be purely rotatory or purely linear, or change direction with gaze in different directions. However, clinicians must exercise great care because small cerebellar strokes or small demyelinating lesions of the cerebellum or cerebellar peduncles may mimic labyrinthine lesions clinically, particularly in the elderly. Common causes of vertigo in the elderly include benign paroxysmal positioning, vertigo, viral neurolabyrinthitis, trauma, toxins, migraine, and posterior circulation or labyrinthine ischemia, particularly associated with posterior inferior cerebellar artery or anterior inferior cerebellar artery ischemia. The proportion of elderly patients with cerebrovascular events among those presenting with dizziness is low, but a thorough evaluation is warranted because the consequences of missing a stroke can be severe. Isolated vertigo can rarely be the only initial symptom in patients with an acute posterior circulation, ischemic stroke, or hemorrhage, and this can even more rarely mimic peripheral vertigo. Small ischemic strokes presenting with severe vertigo may be caused by lacuna and non-lacuna mechanisms. Diabetes appears to be an important risk factor for acute stroke in patients presenting to an emergency room with acute persistent vertigo. Autoimmune vertigo occurs when an abnormal immune response is directed against the inner ear, with or without systemic autoimmune conditions. There may be functional or anatomic alterations with an inflammatory reaction that may be devastating for hearing and balance. Diagnosis is based on clinical criteria or a positive response to steroids. Vestibular paroxysmia involves neurovascular compression of the 8th cranial nerve. MRI has very high sensitivity for detecting this compression. The anterior inferior cerebellar artery is the compressing vessel in 3/4 of cases. Carbamazepine and oxcarbazepine are the most effective drugs and are often dramatically effective even at low dosages, reducing attack frequency to 10% of baseline, attack intensity to 15%, and attack duration to 11%. Second-line therapies include lamotrigine, phenytoin, gabapentin, topiramate, or baclofen. Nafrese. Section 9, Diagnostic Evaluation, slides 30-40. The history and physical examination are frequently sufficient to classify vague complaints of dizziness into one of the major categories, and perhaps even to suggest an etiologic diagnosis. Provocative testing is helpful in defining the subjective sensation. Rotational testing in the office is performed by seating the patient in a rotary office chair with the head tilted 30 degrees forward, then rotating the patient carefully 10 times over 20 to 30 seconds. Tilting the head forward places both horizontal semicircular canals parallel to the floor and perpendicular to the axis of rotation. The resulting vestibular imbalance produces physiologic vertigo that generally lasts less than 1 to 2 minutes. During this time, the physician can observe peripheral vestibular nystagmus and pass pointing. Caloric testing can also produce vertigo, but is generally much more uncomfortable for the patient and is not recommended for provocative testing. Because different types of nystagmus have different clinical implications, it is important to carefully characterize nystagmus both by its appearance and by any precipitating and inhibiting factors. Nystagmus may be characterized by the symmetry of the oscillations, whether the oscillations are linear or rotatory, and whether they are unidirectional or direction changing. Jerk nystagmus has a clear slow phase drift and a quick corrective phase. Pendular nystagmus is characterized by smooth sinusoidal oscillations. Pathologic nystagmus may be present in the primary position as spontaneous nystagmus, with a change in eye position as gaze-evoked nystagmus, or with a change in head position as positional nystagmus. An important inhibiting factor for peripheral vestibular nystagmus is fixation. While fixating, patients with peripheral nystagmus can use their visual pursuit system to counteract the nystagmus. In contrast, fixation does not suppress central vestibular nystagmus because central lesions damage both vestibular and pursuit pathways. Peripheral vestibular nystagmus is a mixed linear rotatory jerk nystagmus that beats in a single direction away from a hypofunctioning labyrinth. With semicircular duct stimulation or dysfunction, eye movements occur in the plane of an affected semicircular duct. Nystagmus amplitude and frequency increase with gaze in the direction of the quick phases due to summation of tonic driving forces and elastic restoring forces. The presence of any of the following suggests a central cause. The nystagmus has a pendular appearance. It is purely rotatory or purely linear. It changes direction with gaze. It is not suppressed with fixation. Vertigo is mild or absent. Nausea is absent. Or there are central neurologic signs or symptoms. Despite these helpful rules, small cerebellar strokes or demyelinating lesions may mimic labyrinthine lesions clinically, so great care should be taken in excluding a central cause, particularly in the elderly. The Dix-Hallpike positioning test is the gold standard for diagnosing benign paroxysmal positioning vertigo. The patient's head is turned to one side, and then the patient is rapidly moved backward from a sitting to a head-hanging position. Turning the head places the ipsilateral posterior semicircular duct in a parasagittal plane. The examiner maintains the patient in the head-hanging position for approximately 1 minute and observes for nystagmus. Peripheral positioning. Nystagmus is a mixed linear rotatory jerk nystagmus that generally beats upward and toward the undermost ear, has a latency of 1 to 45 seconds, a duration of less than 60 seconds, and lessens with repetition. Central positional nystagmus begins immediately, may be purely rotatory or linear, continues indefinitely, and persists with repetition. Calm but firm reassurance from the examiner is often necessary to complete the maneuver. There are 10 red flags that suggest a central cause for positional or positioning nystagmus. First, the nystagmus begins immediately on assuming the offending head position with no latency. Second, the nystagmus has a pendular appearance. Third, it is purely rotatory or purely linear. Fourth, it changes direction with gaze in different directions. Fifth, it is not suppressed with fixation. Sixth, it continues indefinitely with maintenance of the offending head position. Seventh, it persists with repetition of the offending head positioning and does not fatigue. Eighth, vertigo is mild or absent. Ninth, nausea is absent. And 10th, there are central neurologic signs or symptoms. Central positional nystagmus and vertigo can occur with lesions near the fourth ventricle, the vestibular nuclei, and the vestibulocerebellum, including isolated cerebellar nodulus infarction and cerebellar tumors. The head impulse test or head thrust test utilizes corrective saccades after single rapid head turns to help identify the side of vestibular dysfunction, particularly when spontaneous nystagmus is absent. In this test, the patient's head is turned rapidly to one side by the examiner while the patient attempts to maintain fixation on an object 6 feet or more away. Passive rather than active head impulses are necessary to detect a severe unilateral peripheral vestibulopathy. The gaze of a patient with unilateral labyrinthine dysfunction shifts only when the head moves quickly toward the dysfunctional side, and an oppositely directed compensatory saccade corrects the gaze error. Thus, leftward saccades following rapid rightward head movements indicate right vestibular dysfunction. The head impulse test primarily assesses the high-frequency function of the vestibulo-ocular reflex. Clinicians must be cautious because covert saccades during head rotation may be easily missed. The HINTS examination combines 3 assessments: the head impulse test, nystagmus type, and test of skew. The updated HINTS plus examination adds an assessment of bedside hearing by finger rub. In elderly patients with an isolated acute vestibular syndrome, a normal head impulse test, direction-changing horizontal gaze-evoked nystagmus, a skew deviation, or acute unilateral hearing loss suggests a central vestibular lesion and specifically may indicate a vertebrobasilar stroke. The absence of all of these strongly supports a peripheral basis, such as vestibular neuritis. The acronym INFARCT helps remember central signs: impulse negative, fast phase alternating, and refixation during cover test. However, clinicians must be aware of limitations. Many patients with acute vestibular syndrome and negative head impulse test results are found to have peripheral, not central lesions. Up to a quarter of individuals with acute unilateral vestibulopathy have a skew deviation. Despite the numerous studies promoting HINTS, the individual elements may be misleading at times. Many patients with acute vestibular syndrome and negative head impulse test results are found to have peripheral, not central lesions, including Meniere disease and sudden sensorineural hearing loss with vertigo. Patients with peripheral vestibulopathy may have a skew deviation, suggesting wrongly that the lesion is central. In fact, up to a quarter of individuals with an acute unilateral vestibulopathy have a skew deviation. Some patients with labyrinthine infarction might not be identified with the HINTS plus approach. When used in isolation by emergency physicians, the HINTS examination has not been shown to be sufficiently accurate to rule out a stroke. This emphasizes that HINTS is only a helpful heuristic guide that should be combined with a careful general neurologic examination. The standing test is a structured diagnostic algorithm with sequential steps. First, the presence of nystagmus is assessed with Frenzel goggles in the supine position after at least 5 minutes of rest. If no spontaneous nystagmus is present, the presence of positional nystagmus is assessed using the supine roll test and then the Dix-Hallpike maneuver. If spontaneous nystagmus is present and persistent, the direction is examined. Multidirectional nystagmus and pure vertical or torsional nystagmus are considered signs of central vertigo. If the nystagmus is unidirectional, a head impulse test is performed. A positive hit indicates acute peripheral vertigo, whereas a negative hit indicates central vertigo. Patients with neither spontaneous nor positional nystagmus are asked to stand, and inability to maintain upright stance indicates central disease. The test achieved very high sensitivity of 100% and specificity of 94% for central vertigo. A pilot study has demonstrated that patient-initiated vestibular event monitoring is feasible and may facilitate rapid and accurate diagnosis of episodic vestibular disorders. Using miniature video oculography goggles, adult neurology clinic patients were successfully taught to self-record spontaneous and positional nystagmus at home while symptomatic. The nystagmocatcher is a simple device that can be coupled to any commercially available smartphone. It is placed in front of the eye, and a video recording can be made with the smartphone. This innovative approach represents a significant advance in the diagnosis of episodic vestibular disorders, as it allows capture of nystagmus during actual vertigo attacks rather than relying on clinical examination between episodes. Prompt cranial imaging should be carefully considered in patients with a first attack of acute persistent vertigo presenting to an emergency room, especially in association with central signs or age over 60 years, with male sex and cardiovascular risk factors. When neuroimaging is utilized, MRI is superior to CT for diagnosis of acute stroke and should include diffusion-weighted imaging. However, the diagnostic yield of cranial imaging for acute vertigo is generally low. In a systematic review, non-contrast CT had very low sensitivity of 29%, and MRI had only moderate sensitivity of 80%, missing approximately 1 in 5 patients with stroke if imaging was obtained early after symptom onset. Importantly, a constellation of clinical tests, including HINTS, is more accurate than MRI with diffusion-weighted imaging in identifying small strokes causing an isolated acute vestibular syndrome, especially as MRI with DWI is falsely negative in half of such patients up to 48 hours after onset. Caloric testing may help determine the side of a peripheral vestibular lesion. The patient's head is elevated 30 degrees from supine to bring the lateral semicircular duct into a vertical orientation. Cold or warm water is instilled in the external canal. A normal response to ice water consists of tonic deviation of the eyes toward the side of installation plus nystagmus, with quick phases in the opposite direction. Greater than 20% asymmetry between the two sides suggests an abnormality on the side of the lesser response. Clinical assessment of the vestibulospinal pathways includes pass pointing, where consistent deviation of the arm to one side with eyes closed indicates vestibular dysfunction. With acute unilateral vestibular lesions, patients sway or fall toward the lesion. Tandem walking with eyes closed is a better test of vestibular function than the standard Romberg test when cerebellar and proprioceptive function is normal. In some cases, additional diagnostic tests will be required and should be ordered selectively depending on the type of dizziness and suspected underlying etiologies. Diagnostic studies that may be helpful in selected patients with vertigo not attributable to benign paroxysmal positioning. Vertigo include audiometry, electronystagmography, bithermal caloric testing, brainstem auditory evoked potentials, and cranial imaging. A high percentage of patients with normal examinations and non-specific vertigo suffer from peripheral vestibular dysfunction that can be documented with electronystagmography and rotatory chair testing. Lightweight, high-speed video oculography technology has been applied to measure eye movements in patients with acute vestibular syndrome presenting to emergency rooms. This eye ECG approach has been likened to the use of electrocardiography to diagnose myocardial infarction in patients presenting with acute chest pain. The Bereni Society has established consensus criteria for vascular vertigo and dizziness. For definite acute prolonged vascular vertigo, the criteria require acute vertigo, dizziness, or unsteadiness lasting at least 24 hours, imaging evidence of ischemia or hemorrhage in the brain or inner ear corresponding to the symptoms, and the condition not being better accounted for by another disease. For probable acute prolonged vascular vertigo, the criteria require vertigo lasting at least 24 hours, plus at least one of the following: focal central neurologic symptoms such as hemiparesis or dysarthria, at least one component of central hints, other central oculomotor abnormalities, or increased risk of vascular events such as an ABCD2 score of at least 4 or atrial fibrillation. Because there is a high false negative rate for imaging, serial radiological evaluation may be required. Section 10, Management, slides 44-52. We now move to the management section of our lecture. The management of vertigo encompasses pharmacological treatment, vestibular rehabilitation, canalith repositioning maneuvers, and in rare cases, surgical intervention. The approach depends on the underlying etiology, the severity and chronicity of symptoms, and the patient's overall health status. Drug review is a fundamental first step in managing any patient with dizziness or vertigo. Alcohol can produce a positional vertigo syndrome because it diffuses into the labyrinth and changes the specific gravity of the cupulae of the semicircular ducts. Aminoglycosides can produce irreversible damage to labyrinthine hair cells, resulting in sensory disequilibrium, oscillopsia, hearing loss, and tinnitus. Similar clinical pictures can occur with antimalarial agents, cisplatinum, ethacrenic acid, furosemide, minocycline, and salicylates. The dysfunction is usually reversible with furosemide, minocycline, and salicylates. The elderly are particularly susceptible because they are more likely to receive ototoxic drugs, have less vestibular reserve, and are more likely to have impaired renal function. Vertigo, especially acute persistent vertigo, may be alleviated with vestibular sedatives. Severe forms are especially distressing when accompanied by nausea and vomiting. Antivertiginous medications with both sedative and antiemetic effects are helpful, such as promethazine, droperidol, and dimenhydrinate. Chronic recurrent vertigo is less distressing and interferes less with daily activities. Agents with less sedating properties, such as meclizine and trimethylbenzamide, help patients carry on with their normal routine. Agents that commonly cause confusion due to central nervous system, depressant, or anticholinergic properties should be utilized carefully or avoided in the elderly. Parenterally administered drugs that may produce hypotension or respiratory depression should generally be used only in a hospital setting. For vestibular paroxysmia, carbamazepine and oxcarbazepine are first-line and often dramatically effective even at low dosages. Some types of vertigo are amenable to specific curative therapies. Most notably, benign paroxysmal positioning vertigo responds excellently to canalith repositioning maneuvers. The Semont liberatory maneuver and the Epley maneuver are the most commonly used techniques. Although surgery was previously employed for BPPV, it is now rarely necessary except in exceptional refractory cases. Vertigo associated with migraine may respond to both abortive and prophylactic anti-migraine treatments. Other forms of episodic vertigo, such as Meniere syndrome and vestibular paroxysmia, may benefit from pharmacological or surgical therapies. For Meniere syndrome, various medical and surgical options are available. For vestibular paroxysmia, carbamazepine and oxcarbazepine reduce attack frequency to 10% of baseline. In patients with acute persistent vertigo from peripheral vestibular lesions, recovery occurs more rapidly and more completely when vestibular exercises are begun as soon as possible after the onset of symptoms. The exercise protocol progresses through phases. Initially, while still in bed, patients repetitively move their eyes up and down and side to side, first slowly then quickly, followed by head movements. When sitting, patients practice eye and head movements, then rotating head and shoulders and bending forward to pick up objects. While standing, eye and head movements are practiced, along with changing from sitting to standing with eyes open, then closed. Finally, patients practice walking, turning, standing on one foot, climbing steps, and playing games involving stooping and stretching. Exercises should be performed for at least 5 minutes several times per day. Specific positions that precipitate vertigo should be repetitively performed to facilitate compensation. Treating patients who have acute vestibular neuritis with vestibular exercises is apparently as effective as treating them with corticosteroid therapy in terms of clinical, caloric, and otolith recovery. Corticosteroid therapy seems to enhance earlier resolution of symptoms of acute vestibular neuritis, with no added benefit in long-term prognosis. A number of variations of vestibular exercises have been advocated, and evidence is insufficient to support one form over another. Antivertiginous medications can be used during the exercises to help control both the vertigo and the autonomic symptoms. Although there are theoretical reasons to imagine that vestibular sedatives may limit the efficacy of vestibular exercises, there is no solid evidence that such medications affect either the rate or degree of vestibular compensation. Instrumental rehabilitation training on a moving platform can also be effective for treating vestibular balance disorders. Surgery is needed to manage vertigo in only a small percentage of patients. Even in an institutional vertigo clinic, only 1% is managed surgically. Useful disease-modifying surgical treatments in highly selected patients include perilymphatic fistula repair and microvascular decompression of the vestibular nerve. Labyrinth destructive procedures include transmastoid labyrinthectomy and labyrinthectomy with vestibular nerve section. Vestibular neurectomy for intractable vertigo is generally well tolerated and can effectively relieve intractable vertigo due to Meniere disease, uncompensated vestibular neuritis, and other vestibular neuropathies. Patients with mass lesions of the labyrinth or internal auditory canal, such as vestibular schwannoma, may benefit from combined disease-modifying and destructive procedures such as translabyrinthine excision. In medically intractable cases of vestibular paroxysmia, retromastoid craniotomy and microvascular decompression can be considered. Section 11, Conclusions, slides 51 to 55. As we conclude this comprehensive lecture on vertigo, let us review the key takeaways and clinical pearls that will help you in your daily practice when encountering patients with vestibular complaints. Let me summarize the key clinical pearls for diagnosing vertigo. The history remains the most powerful diagnostic tool. The duration of vertigo episodes significantly narrows the differential diagnosis, from seconds in BPPV to hours in Meniere syndrome. Always perform the Dix-Hallpike maneuver in patients with episodic vertigo. Use the HINTS examination for patients presenting with acute vestibular syndrome, but remember its limitations. Combine clinical tests with neuroimaging when indicated, especially in elderly patients with vascular risk factors. Remember that a constellation of clinical tests is more accurate than MRI, with diffusion-weighted imaging in identifying small strokes causing an isolated acute vestibular syndrome, especially in the first 48 hours. For management, always begin by reviewing the patient's medications, as drug-induced dizziness is common and often overlooked. For BPPV, canalith repositioning maneuvers such as the Epley or Semont maneuver are curative in most cases. For acute severe vertigo, use vestibular sedatives with antiemetic properties such as promethazine or dimenhydrinate. Begin vestibular exercises as early as possible after symptom onset to accelerate recovery. For vestibular paroxysmia, carbamazepine and oxcarbazepine are dramatically effective. Surgery is reserved for less than 1% of patients and includes options such as perilymphatic fistula repair, microvascular decompression, and vestibular neurectomy for intractable cases. The field of vertigo diagnosis and management continues to evolve. Lightweight, high-speed video oculography technology is being applied to measure eye movements in patients with acute vestibular syndrome in emergency room settings. Patient-initiated vestibular event monitoring using smartphone-coupled devices like the nystagmo catcher may facilitate rapid and accurate diagnosis of episodic vestibular disorders. Clinical decision algorithms such as HINTS and standing continue to be refined and validated. Our understanding of the neural mechanisms of vestibular compensation continues to grow, which may lead to more targeted pharmacological interventions. Personalized rehabilitation protocols based on individual patient characteristics and vestibular function testing may improve outcomes in the future. Thank you for your attention throughout this comprehensive lecture on vertigo. We have covered the definition and classification of vertigo, the anatomy and pathophysiology of the vestibular system, clinical manifestations and case studies, the biological basis and epidemiology, differential diagnosis approaches, detailed diagnostic evaluation techniques including the Dix-Hallpike maneuver, head impulse test, HINTS examination and standing algorithm, neuroimaging considerations, and comprehensive management strategies including pharmacological treatment, vestibular rehabilitation, and surgical options. I hope this lecture has provided you with a thorough understanding of vertigo that will enhance your clinical practice. Please feel free to ask any questions.